this lecture, are you following me?
Yes,
Yes.
doctor.
Yes,
Yes.
doctor.
Okay, good. Because like anytime if you're not able to hear me, just Rami send me a WhatsApp, okay? It should not be like that. I am talking and like you are not able to listen, okay? So in this case, we are going to talk about uh, pneumonia. What is the definition, causes, pathogenesis, and all. Something about related to the smoking-related lung diseases. Okay, though like a lot of diseases, as you know, like we read about in the COPD, emphysema, and the pneumoconiosis, there is smoking is related. Even when you see about the lung cancer, that is also related to the smoking. Okay, so it's not like that what the diseases which we are going to know what are the smoking related diseases. It doesn't mean that the COPD and about your lung cancer or emphysema, chronic bronchitis, even bronchial asthma, it's not related to smoking. Smoking is one of the common etiological factor for the respiratory diseases, but there are few rare lung diseases which is specifically related to the smoking. So we'll just know about a brief about those two diseases, and then we talk about the lung cancer. As you know, the topic over here is not matching with your case. Maybe the pneumonia will be matching, but you have a very strong ILO. When we go about your program learning ILO or the course ILO, there is one thing is very important about, you must know about the smoking related lung diseases, that is there. And the lung cancer has been added from our side, because you know the lung cancer, when you learn about the lung cancer, it is one of the commonest cancer and one of the common cause of, like, leading cause of death both in male and women. Okay, so that's why lung cancer has been added. So you must know, when we are dealing with the respiratory pathology, we must touch all the commonly occurring diseases and some diseases in depth. Okay, so this is our ILOs, and now we'll move to the pneumonia. So what is pneumonia? Actually, we you must have heard about pneumonia a lot from your childhood till now, and you will be hearing pneumonia throughout your practice. Okay, so it is nothing but an inflammatory condition of the lung parenchyma. There is inflammation, and most of the time, this inflammation is induced by infection. Most of the time, but there are few toxins, few chemicals can also induce inflammation and pneumonia in the lungs. So, basic definition of the pneumonia is inflammatory condition of the lung parenchyma. Actually, some people call pneumonia as a pneumonitis also. So that is pneumonitis. This comes, it is inflammation of the lung parenchyma. Okay, and what happened over
Doctor,
there? Yes,
there is a problem in the slides.
uh, like you're not able to see.
We can see it, but it's not moving. Try sharing your screen, doctor, not the window.
Again, I will do the screen, but I am in the window actually. Okay, 1 second. Okay. So let me see. I will download the PowerPoint over here. Okay, now it is clear. Is it moving?
It's not moving, doctor.
Moving?
No, doctor.
We can just
Not
see the
moving?
first slide.
Doctor, when you press the share button,
Okay.
doctor, I think you see two options. Is it correct, doctor?
Yeah,
Yeah, share a screen or
I
window.
see windows at the screen.
Yeah,
Yeah.
choose sharing the screen.
Okay, I'll see to it. Okay. Okay, now you're able to see the second slide.
Yes. What is
Yes.
pneumonia?
Is it moving?
Yes,
Is it
doctor.
moving?
Yes, it
Yes.
is.
It is moving.
Okay. So about VR, I'm really sorry for this, all these like inconveniences, but inshallah we will finish on time. Okay. So what is the basic pathological mechanism or basic pathogenetic mechanism? Is there a filling of alveolar spaces with the fluid, and later on this fluid becomes solidify and lead to the lung elastic lung tissue will become solid tissue, and that in the clinical terminology we call it as a consolidation. Like when you see the x-ray chest, and like if you are like you are an intern, you see the your like registrar will ask you, do you see the consolidation? Is there any consolidation? So what do you mean by consolidation? When he's talking about consolidation, it is he's talking about any solidification of the lung parenchyma, and most common cause, but all or but you can say, like when say consolidation, it means pneumonia. Okay, so there is consolidation. And why this consolidation? Because alveolar space is filled with the fluid. And pneumonia, and along with influenza virus, it's the sixth leading cause of the death in the world. Okay, and one of the most common cause of death in hospital setting. Okay, and it doesn't have any prediction for the any sex and race. It affects all the gender and all the races throughout the world equally. Okay, and as I already told you, it is, if you look for an infection related mortality, the pneumonia is the leading cause. The pneumonias are the leading cause for the infectious related morbidity. And you see the death rate increases with the comorbidity and age. If an elderly patient suffers with pneumonia, there are high chances that he will might let up into the complication and death, and so goes with the newborn and infant. So that's why extremes of the age and comorbid condition, like someone who is suffering from various diseases which can affect the immunity, the systemic or generalized immunity or the localized immunity of the respiratory system. As you see, you all now we know all pneumonia, we know all about the COVID pneumonia. You see, the COVID pneumonia was most severe in those who has comorbidities. Okay, so same goes with the bacterial pneumonia for us. So you call it for any pneumonia. If you have comorbid condition in the form of the systemic diseases like diabetes, immunosuppression, hypertension, cardiovascular diseases, renal diseases, central nervous diseases, or any disease which lead to the local defense mechanism of the lung. Okay. Now we have certain definitions, certain clinical terminologies, which is usually used in the practice. Okay. So these are, what are these? Like one is the CAP, community acquired pneumonia. So at you see community, so it comes from the community. So lung infection in otherwise healthy individuals, the one who does not have any pre-existing diseases, does not have any condition, and these infections does not come from any like specific setup. It is come from the normal environment where they live. Okay, we are living in our environment, we are healthy, and we get pneumonia, we call it as a community acquired pneumonia. The another one is one of the important or riskier one is the healthcare associated pneumonia. Okay, so what is the difference between healthcare associated pneumonia and hospital acquired pneumonia? So healthcare associated pneumonia that develops within 48 hours of the admission in the following patient. Okay, a person who has been hospitalized in the acute or ICU for more than 2 days in the past 90 days. If someone has been hospitalized in the last 3 months for more than 2 days in the acute care or intensive care unit, and he again admitted in the hospital and developed the pneumonia within 48 hours, we call it as the healthcare associated pneumonia. Then someone who is living in the old age home or long term care facilities or some nursing home where they get just treatment for the Alzheimer's or Parkinson's or chronic diseases, if they get admitted due to some other condition and develop pneumonia within 48 hours, we call it as a healthcare associated pneumonia. Those one who is on the dialysis for the last within 30 days get admitted to the hospital and get pneumonia within 48 hours, healthcare associated. Then the one who is on the home IV therapy or home wound care in the past 30 days. Some people who are healthy, they don't require hospital administration, but they need their wound to be clear. They should get the IV, some IV medication. If they get admitted to the hospital and develop pneumonia within 48 hours, healthcare associated pneumonia. Or someone who has a family member with the multi-drug resistance organism. What is MDR? Multi-drug resistance organism or pathogen, and they get admitted to the hospital and develop pneumonia within 48 hours, we call it is a healthcare associated pneumonia. Anyone who is getting admitted to the hospital and developing pneumonia after 48 hours of admission, we call it as a hospital acquired pneumonia. Okay, so there is a difference between healthcare associated pneumonia and hospital acquired pneumonia. And ventilator associated pneumonia is especially seen in the patient who was on the ventilator and after 48 hours of intubation or after 48 hours of you putting them on intubation. Okay, so this is all the definition. Just remember about this time frame within 48 hours and among these individuals. Okay, if it develops after 48 hours, we call it as the hospital acquired pneumonia. Okay. Now, what are the risk factors? There are two risk factors. One is the systemic diseases, like anything which leads to the suppression of immunity, that will be a cause for the pneumonia. That is a systemic cause. But at the same time, you must understand the local defense mechanism of the lung. Okay, so what are the local defense mechanism of the lung? We have like loss of suppression of the cough reflex as seen in the anesthesia, then dysfunction of the mucociliary apparatus, which can be seen in the patient with the smoking or those who get like exposed to the hot corrosive gases, viral diseases, genetic defects, or ciliary dysfunction like a syndrome, immotile cilia syndrome, because you know the cilia will clear all the infection out through the cough. Okay, then accumulation of secretion, because secretion whenever it get accumulated anywhere, it is a very good culture media for bacteria to grow. And in condition of the cystic fibrosis and bronchial obstruction, you get uh, accumulation of secretion and you get high chances of pneumonia. As you see in the COPD patient or asthma patient, they have increased secretion and obstruction, they are increased risk of pneumonia. Then there are certain the mechanism which interfere with the phagocytic mechanism. So the one who is on the alcohol, tobacco, smoking, and like hypoxia, oxygen intoxication, and pulmonary congestion and edema. These are all the risk factor for the pneumonia. You have different types of pneumonia. Sometimes we call them according to etiology: viral pneumonia, bacterial pneumonia, fungal pneumonia, tuberculosis. Then you have like non-infective one like toxin induced, chemical induced, or aspiration. Aspiration, usually aspiration of the food particle. If someone who is unconscious, he vomit and the food particle or gastric secretion goes into the respiratory tract, and that causes aspiration. Someone who is eating while lying down, it can also lead to the aspiration of the food in the respiratory tract, and that can also lead to, and this is like one of the commonest type of pneumonia. Then we have like morphological or pathological type of classification, which we use as the lobar pneumonia, when the entire lobe of a lung is involved. Bronchopneumonia, when like you see the patchy area of involvement in the entire lung parenchyma, not any single specific lobe. Okay, but entire lobe, like suppose upper lobe or right lower lobe, left lower lobe, it is involved, we call it as a lobar pneumonia. Interstitial pneumonia, when the interstitium is involved. Okay, as we see the interstitial fibrosis, here we get the interstitial pneumonia. Duration like acute or chronic, you have like community acquired, hospital acquired, typical pneumonia, atypical pneumonia, primary pneumonia, as you see in the primary, like in cases of the lung diseases, or secondary due to patient you see in the diabetes mellitus, or from some other place coming to the lung infection in the kidney, and from there it coming to the lung, we call it as a secondary or hematogenous pneumonia. So this is the different types of pneumonia. And in the previous slide, we have seen the risk factors. These risk factors usually with the local defense factor, but there is also the systemic, whenever there is also the loss of systemic defense factor, as we see in the HIV, diabetes mellitus, immunosuppression, hypertension, cardiovascular diseases, extremes of age. In that condition also you can have the pneumonia, but this is the local risk factor, like suppression of the cuff reflex. Cuff reflex is always protective, and when the condition which lead to the suppression of the cuff reflex, as you see in the loss of consciousness or altered sensorium, patient under anesthesia. That's why always in the anesthesia, any person who is going for like any surgery, we keep them nil by mouth. We don't give them food at least 8 to 12 hours before surgery. You all know this well. And what is the reason for that? To prevent the aspiration pneumonia, because due to anesthesia, cuff reflex is suppressed, and when you give the anesthesia, all the body reflexes become loose, they relax. So the food from gastric contents can come into the respiratory secretion and go into the lung and cause pneumonia. Okay, then this cilia is very important. If it get defected, as you see in the smoking, inhalation of the some toxic gases, or genetic defect in the ciliary dysfunction, immotile cilia syndrome, or you call it as a Carter-Jenner syndrome, where the cilia are immotile. So these patients are risk of developing of pneumonia. And if it is a male patient, he will be infertile, because the cilia in the vas deferens or the genital tract from the which carries the sperm out of to go. So that if cilia is not there, the sperm will not come, and that person will be, though he must be having the normal sperm in the testis, but this sperms is not able to come out. So they will have infertility. Okay. And cystic fibrosis and pulmonary congestion and edema, because whenever you have congestion and edema, fluid is a very good culture media for growing of the organism. Okay, so clear about the pneumonia types and the risk factors. Now, this is a table which we took from the Robbins, and this is what we get different microorganisms associated with the different type of pneumonia. Like community acquired pneumonia, you have the common bacteria which is present in the community, which can be typical and atypical. Okay, so you have Streptococcus pneumonia. Another name for the Streptococcus pneumonia is pneumococcus, Haemophilus influenza, Moraxilla catarrhalis, Staphylococcus aureus. Okay, so this is the, in this table, we'll come back to one more chart, or you may be seeing in the microbiology of the respiratory tract infection. There are organisms which causes typical community acquired pneumonia, organism which causes atypical community acquired pneumonia. Okay, so you need, in that atypical, you have got Mycoplasma, Legionella, Chlamydia, these are all atypical. Okay, and this upper one are the Streptococcus, Haemophilus, Moraxilla, Staphylococcus. These are the typical. Okay? Then we have healthcare associated pneumonia. These are usually caused by methicillin resistant Staphylococcus aureus, Pseudomonas aeruginosa, and the later on Streptococcus pneumonia. Okay, so when you've been asked about which is the commonest organism associated with the healthcare associated pneumonia, the first one should come Staphylococcus or MRCA, methicillin resistant Staphylococcus aureus. Okay, MRSA. Then we have hospital-acquired pneumonia. Hospital-acquired pneumonia usually by the gram-negative bacteria, in which comes the most commonly by the Klebsiella and Pseudomonas. Klebsiella and Pseudomonas are the gram-negative rods which are commonly associated with the hospital-acquired pneumonia. Again, this culprit MRSA will be responsible for the hospital-acquired pneumonia. Aspiration pneumonia, usually the bacteria is coming from the oral cavity or it is from the GIT. Okay, so you have bacteroides, parvitiola. Chronic pneumonia usually caused by like some specific type of fungi, endocardia, actinomyces, the granulomatous inflammation, which you have seen in the your inflammation lecture of the life cycle. You have the mycobacteria, atypical mycobacteria, certain fungi. When you must have seen in the your introduction to mycology lecture, histoplasma and all those things. Then you have certain type of pneumonia which from the beginning causes necrosis and the lung abscess. Okay, and in this you have like more commonly the anaerobic bacteria. Okay, which may be with or without aerobic infection. Okay, so you have Staphylococcus aureus, Klebsiella, Streptococcus pyogenes, and type 3 pneumococcus. Okay, and another one is the pneumonia in the immunocompromised host. So when the like HIV or the one who is on the organ transplant, immunosuppression, chemotherapy, in that you have like pneumocystis jirovecii. You have learned this very well in the your case 5 HIV life cycle case 5 HIV infection. Then you have cytomegalovirus, mycobacterium, avium intracellular complex. If you have read your additional resources, you know also like when the CD4 count is less than 200, less than 100, and less than 50, what type of organism can cause. Okay, so just try to remember the commonest organism causing pneumonia are the pneumococcus, Haemophilus influenza, Legionella pneumophila, Mycoplasma pneumonia, MRSA, Klebsiella, and Pseudomonas. So these are the commonly seen bacteria. MRSA, healthcare associated pneumonia. Klebsiella and Pseudomonas, hospital-acquired pneumonia. Pneumococcus or Streptococcus pneumonia, community-acquired pneumonia. So defense mechanism you have seen when the defense mechanism is lost, usually this bacteria get to the respiratory tract. So how they come into the respiratory tract? Commonly when even in the healthy individual, because community acquired pneumonia is usually in a healthy individual. So what happened? A person suffer from a viral infection. This viral infection will reduce the immunity of the respiratory tract infection. They will cause some abnormality of the macrophages. They might cause some abnormality of the cilia. They might lead to excessive production of the secretion. So this will lead to development of a bacterial infection. Okay, and even though in a healthy individual also, it usually seen in a patient's pneumonia usually develop in a patient extremes of the age, like infant, newborn, or very old patient, and those with the chronic diseases. Okay, in that condition also mostly this community acquired pneumonia develop following a viral respiratory tract infection. Okay, so these are the chronic diseases like congestive heart failure, COPD, diabetes, congenital or acquired immune deficiency, and decrease in absent splenic function. Yes, you must remember also the one who has undergone splenectomy due to some tumor or some trauma, they will have high chances of development of the encapsulated bacterial infection. The most common encapsulated bacteria is the Streptococcus pneumoniae or pneumococcus. Okay, so a person with the splenic loss of spleen or asplenic function, especially you might see the loss of spleen in a sickle cell patient also, even though they don't have undergone any surgery, but due to chronic fibrosis, spleen lost completely all its function, and this condition you get capsulated bacterial infection, pneumococcus. Okay, and these bacteria when they go into the lung, they bring about the abscess, inflammatory response. This inflammatory response will lead to increased vascular permeability, production of some inflammatory cytokines, culture of the fluid. With passing of time, this fluid will get solidify and lead to the development of the solidification or consolidation of the lung. Is it clear so far for you?
Yeah, it's clear, doctor.
Yes.
Rami? Clear, okay.
Yes, doctor.
Now the morphology. Okay, as whenever we talk about morphology, we talk about the bronchopneumonia or the lobar pneumonia. So bronchopneumonia, we see the lobular or patchy consolidation throughout the lung parenchyma, even or throughout the one of the lobes of the lungs. You see the one area of consolidation, then normal tissue, then consolidation. So this consolidation will be patchy. In that condition, what is a bronchopneumonia? Or sometime we see in the lobar pneumonia, the entire lobe of a person has become solidified or consolidated, and this is called as a lobar pneumonia. Okay, consolidation of a large portion of a lobe or an entire lobe. Even if suppose this half of this lobe is involved, we call it as a lobar pneumonia. And in the lobar pneumonia, you get a very characteristic stages of the inflammatory response. The first thing becomes congestion, because there is inflammation, there is increased vascular permeability. These increased vascular permeability, there is excessive number of the blood vessels, there is some RBCs, so the lung will become congested because of the increased vascular dilatation. Then this dilatation is followed by increased permeability. With the permeability comes a lot of RBCs in the lung parenchyma, and lung start to become solidified. Elastic tissue will start to become solid like a liver. That's why we call it as a hepatization. And because of the excessive amount of RBCs, we call it as a red hepatization because it looks red. Then after a few weeks or after a few days, like 7 to 8 days, these RBCs will get cleared off, and there is high amount of macrophages and some fibrin deposit. Okay, and that will lead to these gray color we call as a gray hepatization. With the drugs or with the good immunity, these stages you might not see. You might see the congestion, and with the good immunity or with the use of good antibiotics, you may see direct resolution, or you may see sometime the congestion, red hepatization, resolution, or you might see sometime all the 4 stages in a sequential manner. Okay, and for all the details of the gross and the microscopic pictures, you might follow the practical slides for this. Okay, so what is the difference between clinical difference between the bronchopneumonia and the lobar pneumonia? Bronchopneumonia, usually it is involvement of the entire lung, or means like there is a patchy consolidation. So it is usually seen in the extremes of ages, and it is secondary. Most of the time it is secondary. So this infection has not come from primary from the respiratory tract. It has come through some other focus of infection in the body, like from the brain or from the kidney or from the spleen. This bacteria has come along with the circulation and get lodged different areas of the lung. Okay, it affects both gender, and commonest are the Staphylococcus aureus, Streptococcus, and H. influenza. Lobar pneumonia you see in the usually middle age group, and it is could be a primary lung infection in a healthy individual, means coming from the respiratory tract directly, commonly seen in the males, and 95% of the time it is due to Streptococcus pneumoniae or pneumococcus, or sometime rarely you might find the Klebsiella pneumonia. Okay, so these Klebsiella gram-negative bacteria or pneumococci gram-positive bacteria most commonly. Here you see the patchy consolidation. There is no limitation by any anatomic boundary and can be seen bilaterally because it has come as a hematogenous or the secondary. So you might see the involvement of both the lung. Okay, while here entire lobe or a major part of the lobe is consolidated, it is diffuse, it is limited by the anatomic boundaries, and usually unilateral. Inflammation is over here is acute, suppurative, inflammation associated with the necrosis, and you have more complications in bronchopneumonia than the lobar pneumonia. Here inflammation is acute, but you have lot of fibrin production, okay, and macrophages like along with the neutrophil suppurative, you get the non-suppurative like lymphocyte, macrophages also you see, and the complication in this is less because it is the lung is involved. You give antibiotic, it get clear, but it is the entire lung is involved and there is a lot of inflammation, lot of blood vessels, so it might get like bacteremia or septicemia is more common in the bronchopneumonia than the lobar pneumonia. Clinical features are the same, like you have like high fever with chills, sometime like skin will become like cold, and because of the hypoxia you might see the cyanosis or blueness, like you patient will have cough with sputum or purulent sputum. There may be dyspnea, shortness of breath, pleuritic chest pain is also very common. Usually patient will say whenever he coughs or take deep breath, he feels chest pain. If there is a necrotizing pneumonia or the inflammation involving more of blood vessel, you might see blood in the sputum. Generalized symptoms of the infection like fever, myalgia, weakness, fatigue, muscle aches. Okay, there is also involvement of the like central symptoms like headache. Patient might have loss of appetite, mood swings because of septicemia or profound inflammation. The patient might have low blood pressure. Tachycardia is a sign of infection. Nausea, vomiting, joint pain. These are the non-specific symptoms with the infection or inflammation. So the most common symptom is a high-grade fever, cough with the sputum production, chest, shortness of breath, and pleuritic chest pain. See, that's why we have these symptoms in the highlighted one. High fever with the chills, cough with sputum production, symptoms with the severe infection and inflammation. Complication, as you can might see the formation of abscess in the lung abscess formation. This infection can go into the pleural cavity and the cause accumulation of the pus in the pleura, which is known as empyema. There may be like it will not resolve, so it may lead to the fibrosis and the scarring of the lung parenchyma. Okay, there may be bacteremia or septicemia, which may lead to the infective endocarditis, abscess in the different organs like brain, kidney, or joint, septic arthritis. So these are the complications of pneumonia. So this is all about the community acquired typical pneumonia. Now we have community acquired atypical pneumonia. It is also seen in the healthy individuals. Lung infection and has come from the community only. But as it is not the symptoms and signs and the organisms are not typical, like not commonly occurring pneumococcus or H influenza, the symptom is like also like cough, sputum production, high grade fever is not the typical symptoms, also are not common. That's why it is called atypical pneumonia. So there is not very high sputum production, some moderate sputum production. The physical findings like tachycardia or joint pain, muscle, cyanosis, calmness, cold skins are usually less commonly seen in this atypical pneumonia. The WBC elevation will also be sometime it is normal or not very highly elevated. Okay, if the elevation is there, it is just usually 11,000 or 12,000. While the community acquired typical pneumonia, the WBC will be very high. Okay, you won't find consolidation or exudate. Okay, and the inflammation more in the septum and interstitium. Okay, not in the alveolar spaces. Okay, so that's why it is a pneumonia, but atypical one, which is acquired in the community. So this causative organism are very, very important to know. What are the causative organism for the community acquired pneumonia? The most common one is the mycoplasma. As you must have heard or read in the newspaper, the China, there is another outbreak of pneumonia, which is seen mostly in the children
Doctor,
or the elderly. This is, yes.
Doctor, your sound is not clear.
Yes, please. Okay. So now you. Clear?
Yes, doctor.
Okay. So this causative organism is mycoplasma, few viruses like COVID also is a community acquired atypical pneumonia, chlamydia, interstitial more than the alveolar infiltration. The pleuritic chest pain in the typical pneumonia, where the pleura is not in community acquired atypical pneumonia. So the key concepts of pneumonia are the streptococcus pneumonia or the pneumococcus is the most common cause of the community acquired acute pneumonia. And there is an inflammation, usually involvement of the lobar pneumonia, and the acute inflammation, you might see the like 4 stages very commonly in the lobar pneumonia: congestion, retipetization, great repetization, and resolution. These bacterial pneumonia are usually characterized by neutrophilic infiltration. Okay, while in the viral pneumonia, you may see the lymphocyte, and that too in the interstitium. While in the bacteria, you see the neutrophil in the alveoli, while viral lymphocytes in the interstitium. Other common cause of acute bacterial pneumonia in the community are the H. influenza, M. catarrhalis, okay, Staph aureus, Klebsiella pneumonia, okay, especially if you sometime this question may be asked, not here, if you might get in the
Doctor,
SMLE. That's why I have this point in this. The Klebsiella pneumonia infection usually seen in the alcoholic. Yeah.
your sound is not clear.
Yes.
Your sound is not clear.
Now it is clear. Maybe some network issue. Now you are able to hear me.
Yes, doctor.
Yes.
Okay. So you have sometime you might ask a question, you might get a question in SMLE, like what type of organism most commonly seen in the pneumonia in the chronic alcoholic. Okay, you have Klebsiella pneumonia. With cystic fibrosis, you know that very well. It has been asked to you also. What is the commonest organism in the cystic fibrosis? You have Pseudomonas aeruginosa, and like Legionella pneumophila infection usually seen in the heart and lung diseases patient and organ transplant recipient. Okay, so these are the few salient feature key concepts about the pneumonia. Okay, and you have like community acquired viral pneumonia, in which you get the influenza, metapneumonia, and our coronavirus. Now we go for the smoking related lung diseases, which are there are two common: desquamative interstitial pneumonia and respiratory bronchiolitis associated interstitial lung diseases. So these two names very important you to remember which one of the following is a smoking related lung disease. Okay, so you must remember this desquamative interstitial pneumonia and respiratory bronchiolitis associated interstitial lung disease. These are the two, okay, and these are the findings. To save the time, I will not read. Just like you read it, there is nothing important and like nothing like very characteristic finding over here. Okay, but you must remember these two names, which are not like you have your what you can see like emphysema, chronic bronchitis. These are also related to the smoking or lung carcinoma, but there are like two important smoking, purely smoking related disease. Okay, you have these two names. Okay, now we go to the lung cancer. It is the most frequently diagnosed major cancer and the most common cause of the cancer mortality worldwide. globally, there were 2.1 million new cases and 1.8 million lung cancer deaths. Just see how common it is and the death, how high is the death rate. 2.1 and 1.8. Okay, so it's like almost all the patient diagnosing with the lung cancer, ultimately they are going to die. Most of the patient, and not all, but most patient, it is for the 14% of the cancer diagnosis and 28% of the all cancer related death. And each year lung cancer kills more people than colon, breast and prostate cancer combined. So you see the colon cancer, breast cancer, prostate cancer patient combined, you find the lung cancer deaths are even more than that. Even though the breast cancer is the most common cancer in the female and the prostate cancer is the most common cancer in the male, but the death leading cause is the lung cancer. And it is usually a disease of the older adults, occurring most often between ages of the 55 and 84 years. And the most peak incidence you see the 65 to 75. And very rarely, only 2% of the cases occur before the age of 40. But nowadays, this trend is moving. There you see more of the lung cancer patient between 40 to 50 year of the age, what you used to see before. So what is the causative agent or etiopathogenesis of the lung cancer? One is the tobacco smoking. 80% of the lung cancer are seen in the active or the those who have stopped smoking recently. And you see that how it is common 60 times greater in the habitual heavy smokers. And women, if a women who smokes, they are like much more susceptible to the carcinogenesis in the tobacco than the male. And when you see the association of the lung cancer with smoking, small cell carcinoma is the like almost all the cases of small cell carcinoma are associated with the smoking. Majority of the cases of the squamous cell carcinoma and the few cases of the adenocarcinoma. So the most common cancer related to the smoking will be the small cell carcinoma, even though you have all your options. Okay, small cell carcinoma, squamous cell carcinoma, adenocarcinoma, large cell carcinoma, or the neuroendocrine carcinoma, whatever the name is there, all the cancers are associated with the smoking, but the highest association with the small cell carcinoma. So you cannot say that two answers are matching. So you take out this question, okay? Because doctor told small cell and the squamous cell carcinoma both occurs with the smoking, but the highest association with the, or you have the question, which of the following cancer is most commonly associated with the smoking? Even though whatever the name is there, you have to choose small cell carcinoma. Then you have the industrial hazards, certain working like as you will see in the asbestos, okay, those working in the arsenic, chromium, uranium, okay. Air pollution is also one of the very common etiology for the squamous cell carcinoma. You see there are few patients who never smoke but still get the lung cancer, and there are who are very common, we are smoking for like 60 years but they don't have lung cancer, okay. So there play some role of genetic mechanism also, or some, like some individual are more susceptible to the cancer and some individual are less susceptible to the cancer, okay. So there are certain molecular genetics, like in the adenocarcinoma you have the epithelial growth factor receptor, ALK genes, which usually affect the tyrosine kinase receptor pathway. So this is the mechanism, molecular mechanism for the adenocarcinoma, which is you have the tyrosine kinase receptor or EGFR or ALK genes, okay. The squamous cell carcinoma most commonly associated with the genetic abnormality in the P53 or cyclin dependent kinase inhibitor, which is P16. Or small cell carcinoma, you see the c-MYC gene or RB gene. So this is the molecular mechanism, very important, because in this era, because it has very high mortality, so researches are going on to find out we can get the gene or genetic therapy or targeted therapy for this tumor. As you have seen the Herceptin, or with the breast cancer who are positive for the hormones, you can give them estrogen, or the breast cancer who estrogen inhibitors, or the breast cancer which are susceptible for the HER2 new receptor, you can give them trastuzumab. So that's why that kind of targeted chemotherapy in or gene therapy. That's why molecular genetics is very important to know. It's one of the commonly occurring cancer and with very high mortalities. Classification, there are a lot of classification, but you must remember, according to classification, we have adenocarcinoma, the most common one, followed by squamous cell carcinoma, small cell carcinoma, large cell carcinoma, and others. Initially, the 10 years before, squamous cell carcinoma was the most common lung cancer. But suddenly, within last 1 or 2 decades, the adenocarcinoma has become the leading. As you see the esophageal carcinoma, inshallah, you will learn in the year 3. In the esophagus also, initially squamous cell carcinoma was the most common, but now the adenocarcinoma has become the most common. Same goes with the lung tumor. Okay, so you have the morphology. We see the commonest carcinoma, adenocarcinoma, which is the invasive malignant epithelial tumor of the glandular depression. That's why you see it's adenocarcinoma. And this tumor can also produce mucus, so we may call it the mucin producing lung tumor. Okay, it grows in a various pattern. You may see the acinar, lipidic, papillary, micropapillary, and solid. And compared with the squamous cell carcinoma, these lesions of the adenocarcinoma usually small and located in the periphery. If you get the CT finding and you see there is mentioned the small opacity is a small opacity suggestive of malignancy seen at the periphery of the lung. So you think in the line of adenocarcinoma, but it doesn't go with the squamous cell carcinoma. Squamous cell carcinoma, a large tumor seen in the central bronchus or in the central area of the lung, it is squamous cell carcinoma. Small cell carcinoma, it is usually associated with the highly or very strong relationship with the smoking. And you see here, not the squamous cell, not the glandular cell, you see here the small cell, very small cell with like the nucleus having the finely granular nuclear chromatin. As you put the salt and pepper on your omelet, the nuclear chromatin look like that. That's why you call it the salt and pepper pattern. Okay, and the nuclei are not seen the small in size, very blue cytoplasm. So you get it is a small cell carcinoma. So you might get a histopathological finding from a lung cancer shows an undefined a tumor with ill-defined small cell with a small cell with scant blue cytoplasm, ill-defined cell border, finely granular nuclear chromatin. What is the most common diagnosis? Diagnosis should be small cell carcinoma. Large cell carcinoma is the diagnosis of exclusion. If you don't see small cell carcinoma, you don't see squamous pattern, you don't see adenocarcinoma pattern, you call it the large cell carcinoma, and you can prove it also with the immuno markers, like it is negative for the TTF1 and napsin, which is a marker of adenocarcinoma, or it is also negative for the P40 and P63, which is the marker of squamous cell carcinoma. It is also negative for the marker of small cell carcinoma, chromogranin, synaptophysin, and CD56. So this tumor will not show any one of these markers and not resembling the morphology also. So you call it a large cell carcinoma. So these are all the features. Adenocarcinoma, you see the glands. Here you see the squamous pattern with the keratin formation, the squamous cell carcinoma. Here you see the small cell carcinoma. The nuclear chromatin is like granular, not blue in color. You can see the small finely granules in the nucleus. And this is the large cell. It's a very large cell. You don't find any similarity between these, neither matching to this, nor to this, and nor to this. So we call it the large cell carcinoma. It can spread locally into the mediastinum, into the local nodes, pleura, pericardium, and can go to the distant lymphatic organ, uh, or through the blood vessel. Through the blood vessel, the most common site or most preferable site for the lung cancer to go to the adrenals. Then it can go to the liver, brain, and bone. Whatever the structure which receive high blood supply, it can go to liver or brain or bone or kidney. But the characteristic spread to the adrenals, you see, it is primary carcinoma. You might get a question, not here, but in SMLE, like a patient CT finding show the nodules in the lung and as well as in the adrenals. What could be the diagnosis? It is a primary carcinoma. the primary carcinoma in the adrenals, primary carcinoma in the lung, primary carcinoma in the liver, and so on. So you're also showing a primary carcinoma in the lung, okay? Because the lung cancer has a very high love for the adrenals, so that's why it goes to the adrenals. Clinical features are simple, like patient will have unexplained cough with sputum production. Sometimes they might have blood in the sputum, unexplained weight loss, chest pain, dyspnea. More or less, it is like pneumonia, but it is not responding to any treatment. Okay. So it can have the local effects also, like pneumonia of the involved lung, abscess formation, collapse, effusion, hoarseness of the voice because of the involvement of the recurrent laryngeal nerve, dysphagia because the tumor obstructing the or lymph node pressing on the esophagus, involving of the laryngeal nerve can lead to the diaphragmatic paralysis, destruction of the chest wall, superior vena cava syndrome, Horner syndrome, pericarditis, cardiac tamponade. All these are the local effect of the tumor. And then this lung tumor also have a very specific association, which is called as the paraneoplastic syndrome. And this paraneoplastic syndrome is due to different type of the tumor producing hormones. Suppose small cell carcinoma produces ADH hormone, which causes hyponatremia in the patient. Small cell carcinoma also produces adrenocorticotropic hormone or ACTH that may lead to excessive cortisone production and lead to Cushing syndrome. Squamous cell carcinoma can produce parathormone or parathormone associated related peptide, prostaglandin E, or some other cytokines that can lead to hypercalcemia. Why I have mentioned this name of the hormones and this tumor? You might have get the question, hyponatremia is most commonly associated with which type of the lung tumor, or hypercalcemia is most commonly associated with the which type of the lung. So hypercalcemia, squamous cell carcinoma. Hyponatremia, Cushing syndrome is more commonly with the small cell. Hypocalcemia due to production of which hormone? You might have the PTH, parathyroid hormone, prostaglandin, and calcitonin. Your option should be calcitonin. Gynecomastia in a male patient suffering from the lung carcinoma, which hormone will be responsible for this? Gonadotropin. Carcinoid syndrome due to secretion of serotonin and the bradykinin. Then you have some acetylcholine receptor antagonist, which may lead to this Lambert-Eaton myasthenic syndrome, peripheral neuropathy, acanthosis nigricans, leukomoid reaction, hypertrophic pulmonary osteoarthropathy. These are all the paraneoplastic syndrome. But remember these, all these hormone related, and one, this Lambert-Eaton syndrome. So you must, this is all a homework for you all. Read why Lambert-Eaton myasthenic syndrome occurs in paraneoplastic syndrome. So you all will read about this, why this Lambert-Eaton syndrome happen in the patient, and how do you differentiate it with the myasthenia gravis. Okay, these for you, those who are interested, they can read it. It's very interesting actually. Diagnosis, you do just clinical presentation, not responding to the treatment, you do the X-ray, then you can do the CT scan, MRI, PET scan. You can also take a bronchoscopy, take the wash, alveolar, bronchoalveolar washing, and see the cells whether they are normal or malignant. You can also do the FNAC of the lymph, an enlarged lymph node, where you can find the metastatic deposit of the lung cancer. Sometimes you can take the biopsy. You do the ISC studies to differentiate between whether it is, if it is TTF and NAPCNA positive, adenocarcinoma. If it is P40, P63 positive, it is squamous cell carcinoma. If it is synaptophysin CD56 positive, it is small cell carcinoma. If it is not positive for any marker, it could be large cell carcinoma. Prognosis is very poor. 5 years survival rate is just 15%, and there is some hope for the patient with the small cell carcinoma. They show some sensitivity to the radiation and chemotherapy. If you diagnose early, this patient, the nodules is very small, you can take out surgically that nodule, there is no metastasis, you can give them adjuvant radio and chemotherapy, and you can just increase some survival in these patients. So this is our last lecture of the respiratory pathology. I hope I am clear to you all. Are you able to understand clearly about the able to hear me?
Doctor, we can't hear you.
Now you are able to hear me?
Yes, we can hear you now.
Yes, now we can.
Yeah. So this respiratory pathology is cleared for you all the 3 lecture to final that.
Yes.
Okay, so I believe that the lecture was easy and understandable for you all. You can find like this year, alhamdulillah, we try to modify all the 3 lectures. It's not like the previous one. We have simplified, we have made it small. Previous lectures were a little bit bigger. And we try to include all the important diseases of the respiratory pathology. You can practice, you will remember this pathology, inshallah. I believe so. So without taking much time of you, I will leave and you all are free to join the next lecture. Okay. Thank you all for your kind